Welcome to the session on innovative nutrition commodities. I would like to thank our sponsor for this session, Children's Investment Fund Foundation, for making today's event a reality. I would like to invite now Mercy Lungaho. She's the Director of Child Health and Development at Children's Investment Fund Foundation. Welcome, Mercy.
Thank you, Kalpana. We're very excited to have all of you here and online, and thank you for the panel for joining me. There are two questions that I've heard very common today. What are nutrition commodities? And why are they important to address micronutrient deficiencies in vulnerable populations? I hope we'll get these answers very clearly out of this session. But I want to start with a more fundamental question around data and evidence. Are we collecting the right data in Africa? Are we using it correctly? I have a very powerful panel, I'm told powerful panel, of Jerome Some from Burkina Faso, Dr. Zipporah Bukanya from Kenya, Dr. Maresha Tsesema from Ethiopia, and Dr. Busi Mazia Dixon from Nigeria. So let me start with my favorite country of Ethiopia. Dr. Maresha, you've done a lot of work collecting data on nutrition. Please tell us, is there any example you can share of where data has informed program implementation?
Yeah, thank you, Dr. Mercy, and thank you also for having me. Yes, of course, we have a lot of data, or several data, which we have been collecting as the technical wing of the government of the ministry. Most importantly, I can mention few data which is more importantly related with nutrition commodity. And the first one is we have a series of data on micronutrient survey, which is national, subnational representative over several period of times. And we have also the food consumption survey. This is also related with nutrition commodities. And both are important, especially to develop or design various kind of strategy, including the national food fortification, roadmaps, and supplementation, and so on. And most importantly, also, we are now recently collecting the multiple micronutrient supplementation pilot programs, implementation research, or this is also very important nutrition commodities data, which we have been collecting to improve the program based on the WHO's guidance.
Thank you, Dr. Maresha. It's really clear to me that Ethiopia is not only committed to data collection, but you're aligning what you're collecting with really nutrition policy and programming. Tell us, are there any critical challenges, and what have been the solutions?
Yeah. Thank you again. Yeah, of course, collection of data, especially data related with biomarker, biospecimens, is not easy. And there are many factors and challenges that would affect. And the most important one is the need to have data. This is also an important, and most importantly also the resource, especially micronutrient related data, are very expensive, and getting adequate resource, getting adequate technical capacity, this is a big challenge. And in addition to this also, when you come to the utilization, sometimes the way the data produce and the way that interpret to the program, the policymaker is also sometimes create some difficulty to understand. And sometimes, the implementers or the policymaker or the program implementer, they thought that certain nutrients could be deficient and some are not deficient. The way the data produced might be different than what we think. And creating or, bringing evidence in the way that people, especially the policymakers who are non-scientists, could understand a big challenge. For that, we have a rapid response team, which is connected with the national data repository and analytic teams, which mostly provide evidence to the policymaker, whether it will be supplementation, fortification, or other program, or there will be sometimes a new question that come from the government to understand or to make kind of decision. For example, we have recently made a mandatory food fortification where almost most of the evidence come from our institute. We followed the procedure that I mentioned earlier. So this is the challenge, and we have also a solution, which, as I mentioned, yeah.
Thank you very much. I wonder, Zipporah, the equivalent of a PHI in Kenya would be KEMRI. Drawing from your experience at KEMRI, can you tell us potential solutions that help you around data reliability, accuracy, and utilization?
Thank you, Mercy, and thank you very much for the question. But also just to pick up from previous speaker regarding the cost of micronutrient-related data. I think it's a problem that is not unique to Ethiopia. I think we've all experienced it. But I think we have learned along the way that we need to do things differently. And I think we will draw from experiences from the countries that have already done the surveys. And one of the things that probably we can think about to address those challenges is, do we have to collect all the data we collect at the same time? Is it possible for us to panel the data so that we have different indicators at different time points, with some being very close to, closer, maybe every year, but then we segment some other data to be collected periodically, maybe 5 or 10 years. I think it's at national level, all countries can make that decision. But I'm also thinking we may be able to use opportunities that already exist to embed critical data in terms of collection. We have systems in some of our countries, like in Kenya, we have the DHS, we have the household demographic surveys that have very clear panels that have been put in place. Probably these are also opportunities we can embed critical indicators that we can collect more frequently to support decision making. Because I think our biggest challenge has always been the timeline between data collection and its utilization, and whether it really helps us to solve the problem that we really need to do with that data. But in terms of reliability, I think we have many issues that we need to think about. One of those is the human resource capacity at the different levels, the whole value chain of data collection. How do we support different countries to ensure that we have very clear understanding of the quality of data that we need and how that can be achieved? Alongside that is probably we need to think of developing structures or frameworks which are standard tools that we can lay our foundations on, that we don't have to be reinventing our data collection processes every time we want to collect data to do with micronutrients. One of those is, for example, when you look at DHS, they have a very clear framework which they use, which aligns the processes right from design of the protocol, data collection, data analysis, and even data reporting, so that we reduce that gap between the timelines that we collect the data and the time that we are able to utilize that. And of course, critically is also how do we link this then to policymakers in terms of dissemination? How are we sending out this information? I would imagine that beyond just Kenya and other countries, I'm sure we have data that we have shelved for many years, we have not utilized it, but at the moment we are looking to collect new data. So we think we need to close that gap and see how best to address that.
Thank you, Zipporah, for those nuggets. There's so much that you've said that resonates with me that I want to take a step back and use the example of Burkina Faso to bring out a few critical points. Jerome, coming to you, I want to ask a direct question. Are we collecting the right data? Are we collecting enough data? From your experience, what would you say?
So thank you, Mercy. For me, I think we are not collecting all the data that we need. This is one, but we are also not collecting enough data, I think. And that is because when you think about, first, the frequency of the data that are collected, you may see that some type of data are infrequently collected. But in addition to that, you may also see that there are some typical data, nutrition data, that are not at all collected. So I think for that reason, for instance, taking the case of micronutrient data, there are a lot of countries, for instance, in West African area, that do not have micronutrient data. Thinking also about the individual level dietary data, you could also see that a lot of countries in West Africa don't have any individual level dietary data. And thinking of my own country that I know a little bit more, I will say, for instance, in Burkina Faso, we have a lot of data, for instance, in terms of anthropometric data, IYCF data for children under 5. We also have some data in terms of anthropometric for women of reproductive age that are regularly collected. They may not be used as the way we would like, but at least they are available. You think about DHF, it's regularly collected. Now we have even the stepwise approach to non-communicable disease risk factors survey that is also being collected for twice. So I think there are some type of data that are available. But thinking of the micronutrient data, for instance, we just completed the first micronutrient status survey in Burkina Faso. And thanks to the government of Burkina Faso, thanks to the partners, we are lucky to be able today to say that we will be having some result for these data in order to be able to guide interventions, policies in the country. But we are still hoping to be able to complete the rest of the gap. For instance, we don't have individual level dietary data. And we know that this is really critical for some type of policies that are needed in the country, particularly to improve the nutrition of many people in the country. So I think there is an opportunity to still improve, even though we are now catching up a little bit with all the missing area in terms of the nutrition data value chain.
Thank you, Jerome. I love your response because it's really balanced. But what I'm hearing is that there's an opportunity to use maybe tools like Index 24 app to collect more detailed data on dietary intake. I want to ask you a realistic and practical question. With the insecurity in Burkina Faso, tell us, do you think this is plausible in the near future, in 5 years? What is really the situation?
Really, thank you for bringing this issue specifically, because I know that, a lot of people outside of the country have the same question due to the insecurity situation that we are facing right now in almost all the Sahel region. But I could confirm that despite the insecurity situation, the SMART survey, the National Nutrition Survey that is being conducted every year, is still implementing. So, and we just have an issue maybe not being able to cover the full country. But for now, we are able to cover up to 75 to 80% of the region in the country. So the last SMART survey, for instance, that just being completed will cover about 75% of the country. So I think there are still opportunity to implement, any type of survey that could at least fill the gap, like the individual dietary data that are still needed. And I think if there are partners that are willing to support the government of Burkina Faso, because there was already a momentum that may be turning off, but that could be revived in order to help the country fill at least that gap within our data, nutrition data framework or landscape, basically. Thank you.
Thank you, Jerome. I'm convinced. I think you're in the wrong profession. If you went into law, you do better, I guess. But one country that will not complain about data gaps or a lack of data is Nigeria. I'm so proud that Nigeria has the most comprehensive survey in Africa. They've used global gold standards like Index 24. Busi, many people in the room might not know you, but you're a giant in Africa. We know you. Nigeria has had 3 surveys, 1968, 2001, and 2021. The 2001 survey was led by Busi, starting her career. The 2021 survey was led by Busi again. When a country comes back to ask you for help with a 20-year gap, you know you're special, right? So, Busi, I'm coming to you to ask, based on what I know are deep insights, not just about Nigeria, but of Africa. Given what you've heard from the panel, if you're to tell us what to do right, what to stop doing, what to keep doing, 3 recommendations of how we move forward, what would those be?
Thank you, Mercy. I think I could come with a list of recommendations from here to the US, but she has limited me to 3, so I will give the 3 key which I think can move countries so that they don't repeat the mistakes we have learned. The first recommendation, Zipporah has touched on it, and I'm going to go deeper in it. It is to improve the processes from designing the survey itself to setting the objectives, the questions, the whole process, because we will find that at the end, when you are at the analysis stage, you are coming with a question, but when you look at the data, you did not collect the data for that question you want to answer. You have an indicator. When you look at your questionnaires, you don't have the questions to give you the indicator. And so then a template which will actually help the scientists who are venturing into collecting the data, these particular surveys, will be very useful. From the designing to setting objectives, to selecting the methods that are going to be used in collecting the data, to data analysis plans before the data is collected, so that you go through the whole thinking process of what actually you want to get out of the data. Now, the data we have conducted in Nigeria are actually 2 surveys which are combined into 1 survey, because we have the biomarker component where we have the anthropometry and the biomarkers, and we also have the food consumption component of the survey, which are collected in the same individual from the same time, remembering that you are what you eat. We wanted to see how diet actually influences malnutrition and biomarker. And so then the template, I will not emphasize much on the template, similar to the DHS, which will include the statistical analysis codes for STATA, for SPSS, for SAS. And then in terms of the methodology, you look at a method which will answer your objectives. The survey we conducted in Nigeria is the first one to use the Index 24 app, where we did not use paper, we use an app. And you do a lot of preparations at the beginning of the survey, but it really cuts the time when you are doing data collection for the food consumption data. So that is my recommendation, number 1. That template, we need it, similar to the NDHS, which will tell us the design, the implementation, the data collection, what to avoid when you are planning those surveys, and how you control your quality, your data quality during data collection. The second recommendation will be, when you have the report, how do your stakeholders use the data to inform the nutrition commodities, to inform policies, to inform interventions? And so then you bring together your stakeholders from government, development partners, private sector, NGOs in one room. You look at the report. You develop a plan of action which will cover the different components of the survey where you have highlighted the results. So the results we have seen in the Nigeria survey is actually, it has pushed development partners who were planning to have programs on the right side to actually have programs on the left side. Now, this is a survey where there is a 20-year gap in between. You can now imagine which interventions and programs were implemented in 20 years where the country was shooting in the dark without enough data to channel the programs. And so then my last that was my second recommendation. My last recommendation will be, there should be a political will in conducting these surveys. They are expensive surveys, but they give you a lot of information to take your programs and interventions to target them very well. And so then that political commitment would actually allow the government and development partners to plan the frequency of those surveys so that there isn't much gap. If you say the survey is going to be conducted every 5 years, is it realistic? Is it practical? Would your interventions from the previous survey have matured enough for you to see impact so that you can either modify or continue with the intervention? So I think these are my 3 recommendations. Thank you.
Thank you, Busi. I like how practical those recommendations are, but I'm asking the giant of Africa to walk the talk. Tell us, what's the next step for the Nigeria survey?
We are finalizing the report. And after finalizing the report, we have our data use workshop. Already stakeholders have started using the results of the report. And so we have the data use workshop. We dig deeper into the data because when we sampled for this particular survey, we used the geopolitical zone framework. That means southeast, southwest, south-north, that kind of a language. But now we want to take the data set because nutrition is a multifaceted problem. So we want to take the data set and superimpose the agroecological zone concept. And the agroecological zone will now allow us to say the crops they grow in that locality, in that community. What is their contribution to nutrient intake? What is their contribution to malnutrition? Is there any negative effect? Because we all know that in developing countries, carbohydrate is usually the larger part of the plate. So is there any negative effect which actually comes from production to influencing malnutrition negatively such that we see a high increase of non-communicable diseases? So we have set the path. We are beginning the journey. Come with us.
Thank you. I'm sure they'll all be excited to join the data use workshop or to see insights from there that guide us forward. Thank you very much, panelists. You've heard it. Kalpana, back to you. Thank you very much.
That was one fascinating dialogue from all the way from right data collection to the right data use and the right data insights. Thank you so much, panelists, and thank you, Mercy. We now move on to short presentations, after which we will have the second panel on nutrition commodities. I would like to invite Taslim Uddin Khan, the Managing Director and CEO of Social Marketing Company. Social Marketing Company is one of the largest social enterprises in Bangladesh and is a force behind making MMS in Bangladesh accessible and affordable to millions of women in Bangladesh. Taslim.
Thank you, Kalpana. Welcome once again, everybody. Let's start, with the presentation. Just a very, very briefly, I'm sharing with the Social Marketing Company. Social Marketing Company started its activities in Bangladesh in 1974 with USAID support. Initially, it was PSI, another international NGO, who was involved in the program beginning. And now it's a non-for-profit company, and it's a successful investment of USAID. And in 2014, as a part of sustainability effort, we have developed SMC Enterprise, and Enterprise is earning surplus revenue. That surplus revenue is, being plowing back for program implementation. So it's a different model, sustainable model across the globe. So, and now come to the nutrition, micronutrition situation in the country. You see the graph, almost all the micronutrition, there are some deficiency. This information is from non-pregnant and non-lactating mothers aged from 15 to 49 years. There's 71% vitamin D deficiency, 44% zinc, iron, then folic acid, everywhere there is a deficiency. And now, SMC is a private sector. SMC work with the private sector. So there's a private sector started from graduate doctor who are doing practice is a OBGYN. We have a network of OBGYN, network of pediatrician, and then non-graduate medical practitioner. We have recruited them, build their capacity, train them, and they're offering public health services in the community. The same for Green Star, who are also engaged in the public health activities, who are mostly drug seller and public health product seller. And Gold Star is a network of private sector. That network is the women entrepreneur. They want to be entrepreneur at the community level. We have picked them, provided training, and they are selling SMC product and disseminating health information. So now, it's this project is a partnership between among all partners. Financial support is given by Children Investment Fund Foundation, and prime and advocacy partner is our GAIN, and lead implementer is social marketing company, SMC, and technical support we are getting from Site and Life. Evaluation partner is ICDDRB, and production product is being product by Renata. So it's a concerted effort. And then we started in a limited, Renata is developing the product, and product price is $6 in Bangladeshi taka, 720 taka is very, very affordable for 180 tablets, and developed a comprehensive promotional strategy and include MMS in the existing. SMC is a huge supply chain network because SMC's annual turnover is more than 175 million. So this $175 million, we have supply chain system, and we have integrated it in this supply chain system. If you see here, you will be seeing that starting from production, then warehouse, then all the network, and then our sales officer, our program officer is working, and finally is going to the pregnant woman. And now, over the time, we have developed this strategy we call integration, quote and unquote, integration of MMS and calcium in ANC services. You ask me why I am saying this. There is two Bangladesh demographic and health survey. One is in 2017 and another is recently, just 2022. The 4 ANC service status among the pregnant women have decreased to 46% to 41 in recent one. So that's the alarming situation. So without enhancing the coverage of ANC services, how come I will ensure the coverage of MMS and calcium, for example? So what we are saying, we have three major components. One is, our community mobilization program, which is women entrepreneur. We have, trained them, and they are doing now ANC services. We recruited paramedics, and paramedics is ensuring in 112 areas that. Another one is our non-graduate medical practitioner. Is a big network of 15,000 providers. We have provided them training, and they are now providing ANC services. And also, since OBGYN is also within our network, so we have also oriented OBGYN about this MMS product. So they are now prescribing MMS, and also they are promoting MMS. And that's why it is not only network related, our network related outlet, pharma outlet, also other pharma outlet, the product is available. So it's a national level phenomena across the country. Wherever you will be going in any pharma outlet, there is a possibility that you will be getting MMS. So the major 5 component of ANC services is included. One is weight measurement, blood pressure measurement, urine test for albumin, blood for sugar, and then counseling, and counseling for danger sign of pregnancy and others. But also we have integrated MMS and calcium in that counseling section. That 5 component we are trying to ensure across the country, and hopefully the rate, future survey, we will be seeing within 2-3 years that rate will be higher, much more higher than current. So this is a major, program integration, a train star network, and organize seminars, organize group meeting with pregnant women, and air talk show. I personally attended more than 100 talk show where my counterpart was all the prominent gynecologists, either they are chairperson of the OBGYN society or secretary, or current or former. So all of them, supported and promoted, MMS, and that was really, and full care, they talk about full care. So a congenial atmosphere has been created with that approach. And digital interface, interface system we developed just to get feedback from the user, what they are thinking, and whether they are completing course or how many is stopping in the middle. So that type of information we are getting. If we see, there's a very encouraging graph that every month the sales is increasing, and new intervention we have incorporated in the program. And I am very much optimistic that in every year there will be a 25% growth. And because it's a huge number, we need to cover at least 2 million pregnant mothers in future. So we'll be doing that. And I am very much optimistic. All my partners are optimistic as well that we will be able to do that. And what lesson we have learned? Continued support by the government was useful. Then gynecologist, if we do by our non-graduate practitioners and all others service providers, then very difficult unless we get endorsement from the gynecologist. So the gynecologist can play a very big role since they are within one of my network in the private sector. So they are part of SMC family. So they are helping us, and we have oriented them. So there is a 500 gynecologist playing is very, very key role. Interpersonal communication with the pregnant women is very important to convert them and sustain the use. So that's also, already I have talked TB talk show. And the most important thing is integration in ANC services of MMS and calcium. That played a very, very key role. And I think, just we have organized this strategy, and over time, we'll be seeing a lot of positive, much more positive result, we hope. So that's all. Thank you very much. I want to end here.
Thank you, Toslim Bhai. This is, I think, what's fascinating for me when you talked about the Bangladesh health service is that that's a good example of how robust data can help design programs with intention. Right? So it's not just about MMS as the first nutrition commodity, but you also saw the need for calcium. Yeah? And more importantly, you also try to deliver with precision. And you SMC identified the importance of community engagement as well as OBGYN network for sensitization. So thank you for sharing your insights. Now we will listen to another successful country experience. This is from Ethiopia. I would like to invite Ramadhani Noor from UNICEF Ethiopia. Ramadhani is a nutrition manager and has led several public health programs. And today he will talk about the rollout of MMS through public sector channels in Ethiopia, but also thinking about a total market approach for Ethiopia.
Thank you very much, Kalpana. And on behalf of a bigger team from Ethiopia that's also here, we work together as a team. Happy to share with you the work that we have been implementing in Ethiopia. So building up on on the global evidence that is evolving, but also the global guidance from WHO, and locally responding to what we have learned from the National Micronutrient Survey and the government efforts to respond also and support the nutrition strategy that is drawn in Ethiopia. The government of Ethiopia, through the Ministry of Health, with support from UNICEF, and thanks for the fund that we received from the CIFF Foundation, is designed a demonstration program for the scale-up, sustainable scale-up of multiple micronutrient supplements in the country. And through this, we found an opportunity, one, to use MMS as an entry point to improve the delivery of maternal nutrition services. So it's not just a switch, but there was a lot of, a bigger interest through the Ministry of Health to see how we can make this as an opportunity to improve the services. Specifically, we wanted to see how we could generate demand, getting women to come early for ANC services, but also come more frequently. How can we improve the quality of services, and then improve the coverage, uptake, as well as compliance of ANC services, including the MMS supplements. And secondarily, we also wanted to, through this experience, be able to learn about the market-based approaches, social marketing approach, particularly for MMS, but also we wanted, for the first time, to have a consolidated social behavior change strategy for maternal nutrition services, and more broadly also to start the conversation about how can we promote local production of MMS in a country like Ethiopia. So we designed this demonstration program with two main big sort of components. So there's models. There's a rural model, but also there's an urban model, which I'll share with you in detail. What is so interesting about the Ethiopia demonstration program is that we have had, the behavior change, we have kept it central to this work. So there's a huge investment working with social behavior change colleagues to sort of understand opportunities we have in terms of changing the behavior, not only behaviors of women, but also behaviors of the healthcare providers. And this is really through the whole process, which we call the journey to health, starting from their knowledge, but also when they're having the intent, when they're preparing to access services, at the point of services, what behaviors can we change, experiences that they have while they receive care and after care. And through this, this team is helping us to really kind of come out with a strategy that is broadly going to guide us on how we can deliver social behavior change through and improve delivery of maternal nutrition services in Ethiopia. That strategy has been drafted, and hopefully through this demonstration phase will be validated, and it will be adopted and scaled up for use. We have also been working with, for the first time, established what we call the Behavior Insight Research Development Lab with the University of Addis Ababa that is leading a lot of the behavior change research or implementation research in this space, and it will guide us in terms of how can we promote those right behaviors, how can we get women to come early, how can we make them come more frequently, and how can we not only just influence women to adhere to supplements, but how can we sustain these high levels of compliances beyond the demonstration phase, and particularly through the scale-up phase. One of the innovations, and there are many that they're testing, is the Pregnant Mothers Conferences. These are conferences that are happening monthly at the very lowest level of care, where women who are attending or coming for ANC services will actually be convened on a monthly basis, and this is where there's a group counseling and there's group messaging, filling the gap, knowing that the health extension workers are quite stretched to be able to ensure that they'll have individual counseling, but also bringing all the community structures that we have beyond the health post in terms of delivering the right messages, and also empower women also to have that peer effect in terms of supporting one another to adhere to these interventions. So in terms of the rural model, which is a huge component, so we had started the rollout of the demonstration program around November last year, and the demonstration program is currently running in about 5 regions, in total about 20 districts altogether. We call them warriors. And so far we have reached around, I would say, slightly over 80,000 women. The target is to reach 400,000 women by the end of 2025. So there was a slow start at the beginning with the product importations, but I think we've picked up speed and the demonstration program is going on well, and we are sure that we'll be able to reach that target. I think what is so special about the program in Ethiopia is probably one of the largest demonstration programs we have in the region. And it's implemented in the context of the existing system, which allows us to have a very close learning of what will be the case when we start to roll it up or scale it up through that system. So we had to make a choice. Either you want to do it small and have a Lexus model, or you want to go with the existing system, but really try to learn as much and be able to scale and mimic the situation and that is appropriate for the context. We have also developed this dashboard that collects the data on specific indicators, not only for the program, but also for the social behavior indicators, just so to be able to monitor whether the rollout, especially the accelerated rollout, how well is it being implemented, and whether the delivery of interventions is actually optimal, so that we could anticipate to replicate the impact that we know from this intervention. The next bigger model we have is the urban model, and this is actually into sort of two broad areas. The first area is implementing more or less similar of the rural model, so the delivery of the MMS through the public facilities, the ANC. This is the work that actually we are coming together with the Addis Continental. They have received support from the BMGF, Bill and Melinda Gates Foundation, to implement balanced energy, an implementation study on the use of balanced energy protein supplements among women who are presenting with wasting. So we have leveraged that opportunity to be able to deliver not only just BEP with IFA, but now balanced energy protein supplements together with MMS, and reach women who are wasted, but also those who are not wasted, in 2 subsidies of Addis Ababa, which will allow us to reach around 120,000 women in the next 2 years. I think this will give us, will inform our learning in terms of how these interventions will be implemented in urban settings, but also in the context of Ethiopia, where a good proportion of women, almost close to 60 in some settings, present to ANC with wasting. You know, how can we deliver both interventions and address their experiences, but also improve pregnancy and the birth outcomes. The second part of the urban model is the social marketing approach. We are very excited about this because we have come into a partnership with Maria Stopes International, and we are working towards a program where we could demonstrate in a limited way on how we could deliver multiple micronutrient supplement, particularly the Unimap formulation, under the social marketing sort of market-based approaches. It requires a separate branding for this, so there's a bit of groundwork that needs to be done because we cannot deliver the same MMS that is delivered for free through ANC. But also there's a lot of interest from the MSI because they're already implementing Pregnavit as part of their social marketing portfolio to sort of upgrade it. So we are very excited with that opportunity as well. We do have also started conversations around promoting local production for MMS, so we're sort of forward-looking. And I think for this, the work that has already been done is in collaboration with the Site and Life, where a market-based sort of survey and a visibility study on the potential of local production for MMS has been conducted in Ethiopia. And what we have seen from that assessment report, one, there are many other forms of, I would say, formulations of multiple micronutrient supplements already in the market at much higher price compared to Unimap formulation, which signifies that there is a potential for a market or market-based approaches. What we've also learned is that the price itself of the MMS, I think, is subjective to the supply, but also the demand. The price that we're working on at the moment, at least for the demonstration, is around $4.4 per woman. We have to probably have an add-up of 20% freight, but we believe with increased sort of supply globally and improved global supply chain, that price will go down. Very briefly, I think from this report, what we've learned is that transition from IFA to MMS in Ethiopia is cost-effective. The local production is more affordable than importing. But also we've learned that, there is a potential already with existing pharmaceutical industry in Ethiopia to produce not only for the local market, but also to meet the regional market, which has also additional sort of economic incentives to the country as well. Lastly, I think we are now, as we implement the demonstration program, we are also sort of forward-looking with the leadership of the Minister of Health. And we are at the moment just looking at the next steps, which is sort of focusing on the 4 pillars, on the policy, financing, product, and delivery. And we have sort of identified a set of actions in the next 1 to 2 years. I'll not go into details about it. And also we have seen of what will happen in terms of actions or activities that we need to focus after the decision that will be made, hopefully, by the Minister of Health to sort of scale up these interventions upwards. And what are those interventions that will actually promote sustainable scale-up of MMS in Ethiopia. So I'll end up here, and many thanks to most of the partners that have been part of this work. Thank you.
Thank you, Ramadhani. We saw a very robust example of an innovation which is at a scale-up stage. MMS, the nutrition commodity, by how you're strengthening communities, communication, and channels, both public and private. Now we're going to move a little bit away from scale-up and talk about a nutrition commodity innovation at a very early stage. And the commodity we'll talk about is an enzyme phytase, looking into the evidence around phytase by Professor Michael Zimmerman, who's a professor for human nutrition at the University of Oxford and was formerly as the head of a human nutrition laboratory at the ETH Zurich, Switzerland, and is an expert on early innovations around phytase.
Yeah, thank you, Kalpana. Thank you to CIFF Insight in Life for the invitation to come speak about phytases. And I think, we've seen how MMS are basically a nutrition commodity which is reaching millions of pregnant women around the world. In contrast, and maybe surprisingly, phytase has really not been exploited at all for human nutrition uses. And so I'd like to present some data today suggesting that maybe in the future it should be. Here we go. Yeah, so what is phytase? As mentioned, it's basically an enzyme, but it's important because plants store their phosphorus as phytic acid. So phytic acid is the way that most plants store their phosphorus, and they use this phosphorus to grow. So when we feed plant foods to livestock or to humans, the phytic acid present in these plant foods is an important part of the diet, and yet most of the phytic acid is indigestible. So phytic acid is potentially an important source of phosphorus and has been very widely used in animal nutrition. Monogastric livestock like pigs and chickens can't digest phytic acid, so they're often given phytases. And this is an essential part of good livestock practice. And I was just reading that the global market for phytases for livestock use in 2021 was estimated to be about $500 million US, and that this market is expected to expand to up to $1 billion US by 2030. So these are very widely used in livestock nutrition. The reason that they're really valuable is because, as you can see here, phytases are essentially phosphatase enzymes that are able to remove the phosphorus off of phytic acid. So they can basically break off the phosphate groups, liberating the phosphorus for use. And what's also important about the degradation of phytic acid by phytases is that phytic acid, when it's ingested, can cause other sort of anti-nutrition effects. For example, phytic acid binds very tightly to proteins, to certain amino acids on proteins, making proteins less digestible and less accessible. Phytic acid can also bind to important protease enzymes in the gastrointestinal tract, like trypsin, and make them work less well in terms of protein digestion. Also, phytic acid binds very tightly to certain cation minerals like iron and zinc and calcium, so that when phytic acid is in the stomach and in the duodenum, it can bind extremely tightly to these minerals, making them essentially unabsorbable in humans. So the advantage of phytases in human nutrition might be that they would increase the nutritional quality of some plant-based diets because they might be able to increase not only protein availability, but also mineral availability. Now, I work mainly on iron and zinc, so this is a bit of a focus on mineral absorption and its effects by phytic acid and phytases, but it's been long known that phytic acid is a very potent inhibitor of iron absorption. For example, here's a simple graph showing percent iron absorption from a white bread roll. Absorption is about 13% in iron-deficient young women, and iron absorption in those same women when given high extraction wheat flour-based bread is only 1%. So really massive decreases in iron absorption and similar decreases with zinc absorption from foods which are higher in phytic acid. So the idea would be that if we could break down this phytic acid using a phytase, this iron and zinc might be more bioavailable. And this has been shown. Sight and Life actually supported a series of studies that we did looking at a phytase, which is derived from a genetically modified aspergillus. And we used this basically to try to enhance iron absorption and zinc bioavailability from phytic acid-rich cereals. So this was a nice phytase for human nutrition because it had 2 pH optima, one at 2, so it could work well in the human stomach, and also another pH optima at a pH around the pH of the duodenum. So the idea was that if, for example, maize porridge or wheat porridge was taken in high in phytic acid and fortified with iron, if phytase was added to these porridges or these cereals, that potentially in the gastrointestinal tract, so in the stomach and the duodenum, the phytase would work on the phytic acid, break it down so it was less able to bind to iron and zinc, and these would be better absorbed. So we showed in a series of studies using stable iron isotopes that this was true, that if you added this phytase to a multiple micronutrient powder, it would increase iron absorption by about 2-fold compared to the same micronutrient powder containing iron without the phytase. And then in a study that we did in South Africa with collaborators from the University in Potchefstroom, we looked at how this micronutrient powder containing the phytase would be able to deliver iron and zinc to school children and showed that we could reduce zinc deficiency and iron deficiency to a greater extent than the micronutrient powder with only iron and zinc by adding the phytase. So both in absorption studies and in an efficacy study, these phytases have been shown to be useful in terms of increasing bioavailability of iron and zinc. So I think they have real promise in human nutrition, and I think they might be a future valuable commodity in human nutrition, but they're, as Kalpada said, they're basically at their infancy in terms of what we know about them. And I think the major challenges and opportunities to introducing phytase into the nutrition mainstream, we know that there's clear evidence that they may have benefit, and I think they may possibly contribute, for example, to better iron bioavailability from high phytic acid staple foods, which are often fortified. But there's a lot of remaining knowledge gaps, and I think in order to convince the nutrition community that phytases may be valuable in the future, I think we need to close these knowledge gaps. I think the main ones are issues of thermostability. Many of these phytases are very thermolabile, so if they were placed into cooked maize porridge, for example, there would be a lot of degradation of phytase by high temperature. We don't really know the optimal dosage in terms of amount or how frequently this should be given. We don't really know the appropriate combinations with other micronutrients. And in terms of what would be the best application for these, should it be MMPs or should they be tried for large-scale fortification? And then, of course, we need to explore the effectiveness of available delivery platforms that might be exploited for distribution of phytases. So just a quick summary of where we are in terms of phytases. And I think in contrast to MMS, we're really at the very beginning, but they really show promise. So thank you very much.
Thank you, Professor Michael. Also, thank you for helping us understand for very early stage innovations, what are the key critical areas we need to think about their development to the next stage. With that, we now come to the last short presentation, and after which we'll have a panel discussion. It's a pre-recorded video. Unfortunately, Catherine could not travel to be with us. Catherine Hebert is from Clinton Health Access Initiative, and we have a pre-recorded video talking about an innovative nutrition commodity, the fortified cereals, Super Cereal Plus, which was developed many decades ago, but it was taken to scale, impacting millions of children and pregnant and lactating women through a pioneering social enterprise in Africa, and actually the largest social enterprise in Africa, which is the Africa Improved Foods. And today's presentation is about the impact of scaling up fortified blended foods.
Good afternoon. My name is Katie Abear. I'm a Senior Program Manager with the Clinton Health Access Initiative. Thank you for the opportunity to speak today. I'd like to share a little bit about our experience in scaling up fortified blended foods in Rwanda. This was a government-led initiative supported by CHI, focused on improving access to nutrient-dense, locally produced foods during the first 1,000 days of life. FBF is purchased by the government from AIF at cost, and then the food is distributed free of charge on a monthly basis to children and pregnant and lactating women living in the most vulnerable households as categorized per the National Social Classification Structure. Additionally, the government has set up product distribution and promotion systems to drive uptake at the household level. To evaluate the impact of the national provision of FBF, we conducted a quasi-experimental study that was designed to capture the change in stunting among children 18 to 23 months of age before and after the introduction of FBF. So between our baseline data collection in 2017 and our endline data collection in 2021. Impressively, we observed a significant decline in stunting from 2017 to 2021 among children 18 to 23 months of age living in the poorest households. We also observed important improvements over time in terms of micronutrient status and feeding practices. This provides a concrete example that substantial reductions in childhood stunting can be achieved over a relatively short period of time by ensuring adequate access to and consumption of nutrient-dense foods during the first 1,000 days of life. The government of Rwanda has committed to improving living conditions of vulnerable households and have made strong investments in reducing malnutrition among young children. These investments highlight the impact of their commitment to comprehensive solutions to promote healthy child growth and development.
Thank you, Catherine, if you're online. Now I would like to invite all the presenters for a dialogue on innovations in nutrition commodities as well as their scale-up. Along with our three presenters, I would also like to invite Tariq Hassan, the project manager from GAIN, who is responsible for creating an enabling environment for MMS in Bangladesh, and Dr. Abiba Ayalf, senior manager at Children's Investment Fund Foundation, and a passionate advocate of maternal, newborn, and child health and nutrition. If you could have all the panelists up on stage, then we can get started. While they're taking their chairs, I do have some instructions for participants both in the room as well as online around Q&A. So the conference has an app, and on the app, there is a provision for asking questions. You need to go to programs in the app, select today's session title, which is Innovative Nutrition Commodities, and then click the interactive features button. Then you can type your question in the field, and then you click the green arrow to send it. They've given me an iPad, and I should be able to see all questions from participants both online and in room. So maybe to get started, I'll have the first question to Tariq from Bangladesh. You have successfully introduced a new nutrition commodity, MMS, in Bangladesh. Can you walk us through your remarkable journey? What kind of experiences stand out in this collaborative effort for creating an enabling environment for a new commodity?
Thank you, Kalpana. So the journey of multiple micronutrient for the pregnant women is starting approximately in 2020 in Bangladesh, but the implementation of multiple micronutrient is not new in our country. We already did multiple micronutrient powder for the under 2 years children back in 2007. From 2007 to 2010, we implemented multiple micronutrient powder for under 2 years children, along with the exclusive breastfeeding, complementary feeding, and including the multiple micronutrient powder as a home fortification. From the learning of that program, we also did a market-based MNP or multiple micronutrient program from 2013 to 2018 that was also supported by the CIFF. And at that time, we had also a collaboration with the SMC, BRAC, GAIN, and the government for the multiple micronutrient powder. From that success, we are able to sold approximately 145 million sachets of MNP across the country. And from the success of that MNP programming, and also in 2015, we have a low birth weight survey, first Bangladesh low birth weight survey, which indicates that the high prevalence of low birth weight in Bangladesh is approximately 23%. And also in 2016, we had a anemia consultation workshop, National Anemia Consultation Workshop, which actually indicates that the only iron or iron folic acid is not the cause of the anemia in pregnant women. There are a lot of other micronutrient deficiency contributes the pregnancy outcomes as well as the anemia. That's the thing give us an opportunity to move forward to the government that we can start introducing the multiple micronutrient supplementation for the pregnant women as well. From the 2020, we started the multiple micronutrient supplementation through the SMC. The project is already presented by the Toslim Bhai at the early. We learned few important things that when we are continuously advocating to the government with a good thing and also with a good outcomes and good results, we see some changes in positive changes. Like what I can say that the after successful implementation of multiple micronutrient powder through the business model, government develops a strategy, national strategy for prevention and control of micronutrient deficiency. In that strategy, government comes forward and tell that to tackle the micronutrient deficiency, we can using the proper model for the free distribution, what public sector is doing. They also recommending and suggesting the private sector should come to do some business initiative to improve the public health status. So from that particular point of view, it helps the MMS in our country as well for the business model. And we see that the government ownership is gradually increasing. How we can understand that the government is including the MMS in different policies and guidelines, like National Maternal Nutrition Guideline includes the MMS, along with the iron folic acid as a recommendation for the pregnant women. National Adolescent Strategy also included the MMS. National Plan of Action for Nutrition, it also includes the MMS. And the last and important thing I want to say that the government's commitment and willingness to invest on this, the draft document, which is the most important document in Health Population Nutrition Sector Program, we called it 5th Health Population Nutrition Sector Program for 2024 to 29. Government shows the financial commitment to procure the MMS for the public sector distribution, and they are planning for the next 5 years. They are keeping next 5 years fund for procuring MMS in the public sector. So I think continuous advocacy helps us a lot to make government commit to invest on the MMS.
Thank you, Tariq. And building on your learnings around advocacy and collaboration, I would like to ask Dr. Abiba about her experiences across Africa and how can we foster cross-sector collaboration in ensuring nutrition commodities achieve their intended impact.
Thank you very much, Kalpana. So as we know, nutrition is a multifaceted problem that requires multi-sectoral collaboration at different levels. So I think we know that the different sessions yesterday, today have been talking about that. But add to this also the commodities angle, it would mean that we would also have to think outside of the traditional different sectors. It will become like a multi-sector but multi-level collaboration, and then the different also non-traditional sectors that we have been engaging in the past. So I think collaboration is vital. It's critical. I think we all know that. But to foster this, we need to create some platforms as well as initiatives to bring different stakeholders and collaborators together. One of the sessions I attended yesterday was talking about this same thing in terms of the importance of bringing together the government, academia, the private sector, civil societies together, but depending on the context as well, other collaborators that we don't think about. One of the examples given from the presentation by a colleague from EPHI yesterday was the importance of engaging, for example, faith-based leaders in when they were developing the food-based dietary guidelines, because they are critical stakeholders within the Ethiopian context. So, earlier on with the SMC presentation, that was also again raised in terms of the importance of engaging the private sector, but also the public sector government, the more formal healthcare providers in terms of gynecologists, but also the community health workers and other influencers at the community level. So we'll have to think at multi-level and multi-sectoral collaboration. And I think the different levels will provide different inputs, but also the different groups will have their own roles in terms of this. And to give some examples from Ethiopia, we have the multi-sectoral nutrition body, which provide the overarching kind of collaboration framework. But under that, we have task forces, technical working groups, which take different roles in supporting the rollout of the National Nutrition Program. So in short, collaboration is vital, but we'll have to think of the various collaborators that are relevant for the different contexts.
Thank you, Dr. Abiba. I'm going to try to merge questions I'm seeing that are coming in through this app, but also what I have on my list. I think the next question, building on the lines of challenges and opportunities, not only through collaboration, but also other angles. I'd like to ask Dr. Michael, could you, for early innovations such as phytase, can you share some insights through your journey as a scientist in introducing innovations as phytase? What are some of the challenges that one could face and opportunities to nurture?
Well, I think the opportunities are clearly there. I mean, I'm impressed by, we always talk about iron fortification, mass fortification with iron being an effective and sustainable strategy to control anemia in populations. But I remember one example where I was working with the government of Morocco to develop and plan their iron fortification program, and we were looking at baseline iron intakes in populations with very high prevalences of anemia, and we were struck by the fact that actually a diet based on whole wheat flour is actually very high in iron. But the problem is it's very poorly bioavailable because of the phytic acid in the wheat flour itself. So I was struck by the idea that should we actually top off this already iron-rich diet with more fortification iron, or could we develop a strategy that would maximize absorption of the iron in the native diet? So, I mean, that argues very strongly for an approach like phytase. But again, we're right at the beginning, and I think we need to demonstrate clearly that the addition of phytase to food vehicles can actually enhance delivery of protein and delivery of minerals. We have to demonstrate that this can have clear benefit in terms of clinical outcomes, like perhaps child growth and anemia reduction. So there's really a lot of ways to go to convince the community that this is something that's really ready for prime time.
Thank you. Thank you for sharing these insights. And then along the same lines, Taslim Bhai, what I'm seeing questions on the screen as well, is we saw two very good examples. One from SMC in Bangladesh and then Africa Improved Foods from Rwanda. The role of social enterprise. Can you share some insights on how social enterprises can help meet public health goals, but also how to collaboratively work with the government stakeholders to solve such issues?
Thank you, Kalpana. Let me start with the story of 25 years back. I mean, when the diarrheal disease was #1 killer in the country, in Bangladesh, childhood diarrhea. So what we did, in collaborative effort, it was discovered that, oral rehydration salt, and the marketing responsibility was with SMC. And now, you know how many sachets we are selling? We are selling 1.5 billion sachets. And diarrheal disease now, it is #8, killer. From #1 to #8 within these 25 years. Child mortality decreased, very encouraging information as far as our country is concerned. So why it is happening? It is the power of social marketing. Social marketing, first thing is they have their own brand, then promote that brand, ensure the availability of product, and product is in affordable price. The same pathway we crossed for our contraception market. 60% of total contraceptive is coming from private sector, that is SMC in Bangladesh, and rest 35 is public sector and 5 is others. So why it has happened? It has happened again, the power. Each of the brand we have has a brand, first of all, no product without brand. And then we try to promote the brand, make the product available, and a strong communication campaign for that. And I can, after 10 years, it will happen to full care as well. The full care, the same pathway we will cross. That we are now, full care is our brand, MMS brand. We will be promoting that brand. We will make the product available across the country as much outlet as possible. And also, that time, when, it's a very much affordable price. But SMC is a sustainable organization. Whatever the resource we are getting from CIFF, we are tapped on that. And many expenses, we piggyback to our enterprise to ensure that it, better utilization of resource. And already within existing network, we cover, on more than 100 pharma outlets with our products, and 500,000 non-pharma outlet across the country, huge existence we have. And all these things, I mean, we'll be utilizing for MMS as well.
Yeah.
So that is the...
Thank you, Toslim Bhaiya. You brought in two important points: the importance of soft funding, especially when there is a new innovation that needs to be launched in the country, but also how to leverage the power of markets. I think we'll have one more question for Ramadhani, and then we'll take questions from the room. So Ramadhani, a question for you is how do you integrate nutrition commodity programs into the broader public health ecosystem in the country? Because once the demonstration is done, what next? How do you ensure sustainability?
Thank you very much, Kapal. So I think the issue of integrating these nutrition commodities cut across and goes beyond the MMS. I think for a very long time, in most settings, the focus has been on ensuring that we have the commodities through the health facilities. And as much as that is necessary, but it's not quite sufficient, because we have seen, and COVID has taught us, but also multiple shocks in other settings, that getting commodities through the health facilities and having them present is not adequate. That's a kind of a push mechanism. We need to create demand. We need to generate demand. Yeah. We have to ensure that we go beyond the health facility, and we have seen in several surveys in settings where access to health care is challenged. Coverage of most of the essential services, particularly when you're talking about the commodities, tends to go low. So it's quite important to think beyond the sort of health system, and to think on how we could sort of come up with sort of resilience programming for ensuring sustainable scale-up and delivery of these commodities beyond the health system platform. And I think currently, I'll give an example of some discussions and the work that we're doing in Ethiopia, is really to look at, as in the context of building resilience, how can we sort of respond to the needs with these commodities, whereas, thinking of using mixed approaches beyond the facility delivery, how can we also use other approaches, whether be it campaign or through the mobile health nutrition teams, so sort of enhanced outreach services, but also through the community-based nutrition platforms and so forth. So that's one level. The second level is really on the system strengthening itself, whereas we're looking into how can we create very strong platforms at the community level, beyond the primary health care, the lowest level, which is the health post. So there's, from that point, going to the household level where women are, how can we sort of enhance that structure? And we have an existing structure there that we're working on empowering, so that we can work with them in terms of generating the demand and sort of enhance that pool mechanism for most of these products. And as part of the system strengthening, cut across aspects of supply chain management, information systems, the empowering and capacity building of healthcare workers, and so forth. Right. And the last bit is really on the issue of the sort of knowledge management, evidence, advocacy, whereas, there's sort of need, and this is demonstrated with the very strong leadership we have from the Minister of Health, sort of advocate at upstream level in terms of the right sort of enabling environment, policies, guidelines to drive these products, but also financing mechanisms, and draw very clear sort of roadmaps in terms of how such product can be delivered at an affordable, most accessible, and sustainable way. Yeah. And of particular interest also is to learn on how we could actually learn a bit more on the last mile, particularly on the women that we might not be able to reach oftentimes. Who are these women, and how can we reach them? Because that last mile, I think, research is quite important. So I think this is just to give a very brief sort of experience that we have drawn from the work that's happening in Ethiopia.
You answered a couple of questions that came online together. I think we can take one or two questions from the room, Mr. Gentleman. Yeah.
Hi, my name is Maman Zelani. I'm working for Nutriset. We'd like first to thank all the panelists for the presentations and the clarity of them and the usefulness of it. And my question goes to Dr. Zimmerman. Maybe I want to give you some background before. At Nutriset, we developed a small quantity lipid-based nutrient supplements to be tested, and at the time, this was 2008. We tested it first in Ghana, Malawi, Burkina Faso, sorry. So they are food, complementary food supplements, so to be mixed with complementary food. Within this 20-gram SQLNS, we provide zinc. So the first study, looking at effect on linear growth of using these products for kids from 6 months of age, was in Burkina Faso, where we provided different amount of zinc. Whatever the amount of zinc and the matrix, we use SQLNS and pills. We didn't observe an impact on the plasma level of zinc. So then, because this product was to be used mixed with complementary food that would contain phytate, we decided to run a study in the Gambia using phytase. This is why I'm really interested in what you're doing with your university. And we found actually using isotopic methods that when we use phytase, this Aspergillus niger, the same one, that we actually increase the bioavailability of zinc. But then we were in a situation where we were struggling to actually know to which degree the enzyme should work. Cutting 1 phosphorus bond, 2, so having IP 3, 4, 5, so 6 is not the right one. In short, phytate supposedly has got some biological role in the body when we eat phytate. Should we destroy all of it, like until IP3? And another thing we're struggling with is the analytical method. So is there today a method that can enable us to actually see the progress of the work of the phytase until cutting 1 bond to have IP5, 2 bonds, IP4, and etc. These are my 2 questions.
Yeah, thank you. So yeah, I focused a bit on the effects of phytic acid and phytase on iron bioavailability, but phytic acid is also a very potent inhibitor of zinc absorption because it binds zinc very tightly as well. It's great to hear that you tried the phytase and it seems to have had some benefit. I think that the relative amounts of phytase to iron and zinc in these products still needs to be determined. So I can't give you an answer about what are the doses of phytase that should be given. Probably depends on the phytase, depends on the food matrix. In terms of, the effects, so phytase is an interesting enzyme in that it takes, it basically cleaves off 1 phosphate group at a time. So it goes from 6 to 5. And with each successive, removal of phosphorus, you get improvements in terms of reduced binding to minerals. To what extent you need to degrade the phytic acid, we're not so certain about, although it looks like even small amounts of IP3 or IP4 can still bind substantial amounts of iron and zinc. So when they look at whole foods and look at the amount of phytic acid reduction that needs to be achieved to achieve increases in iron and zinc bioavailability, you really need to decrease the phytic acid level quite substantially. A little bit doesn't help a lot. Those are all very important questions that we still need to examine. Also, there's some very interesting work on the different metabolites of phytate in, for example, human health. There's a very nice paper in Nature a few years ago showing that IP3, for example, derived from phytase action on phytic acid in the gut, might be very important in terms of modulating intestinal health. So there's also components of this phytic acid phytase story that might have other health benefits besides just nutrition. So still a lot to be explored.
Thanks a lot.
Thank you. Thank you, Michael. We can take 1 short question here.
Okay, thank you so much. I have already texted, but let me say it. The question is related for the SMC, related to the WHO recommendation in terms of the operationalization of the MMS using rigorous research. So how does that look like in your country context? The second is the cost component. You said 6.6 USD. Does it affect the coverage, adherence, and so on? And the last one is the transitioning between IFA and MMS. How did you manage that transition? Thank you.
Thank you for question. I mean, first of all, as far as WHO is concerned, it's across the world, I mean, whatever their suggestion and feedback, and that's also a part of us. So, but what we need to do is, MMS is considered in Bangladesh as a drug. And once it is considered as a drug, as a medicine, it need to go through under drug administration of regulatory authority, and it is duly approved by drug administration. So, and my colleague Simon sitting here, he told that it is already in different government protocol. It is included. So it has become a national program, and 2 district country is divided by 64 districts. 2 districts we are not doing social marketing. It is dedicated for UNICEF, and UNICEF is distributing free. So we are testing both free and social marketing approach. Social marketing, almost all the 62 districts, and 2 districts is UNICEF. So that is one thing. Another is the price of the product, I mean, which we have determined is a lot of, I mean, study was there behind that to get the information, willing to pay study we have conducted, and we and Sight and Life, we work together and find out, and the price is very, very affordable. So that's a second thing. And third thing regarding IFA, our recommendation is, I mean, if you take 180, then additional IFA is not required. And that's what we are doing. The result is very good. You know, the last 10, 12 years, even more than 12, 15 years, this IFA government is trying. It's a completely free. And in addition to free, it is also available in commercial market as well. But it's not more than 50%, I mean, IFA use rate. So that's why, to me, as a marketeer, as a social marketeer, the most important thing is to educate the people that they need that. Rather than cost is not barrier, perhaps. If you distribution even free, that is not too much important for me. The most important is your, I mean, communication, your promotion, how stronger it is, so that the people feel that they should use that. Pregnant mother feel that they should use it. Thank you.
Thank you, Taslim Bhai. Now I'd like to invite Dr. Abiba for closing remarks and key takeaways, and a round of applause for our panelists here.
Pulling together the takeaways, because it was a very, very rich conversation, very interesting presentation. So I won't be, I think, giving justice to the presenters and the panelists, but I'll try to kind of point out 3 or 4 major takeaways from this conversation. So the first one from the first interesting conversation around data is, I think, the importance of having the right data of reliable and good quality in a timely manner to inform and drive strategies and implementation. I think that is the one that came out clearly from the conversation among the different experts and the scientists around data. And I think as part of that, also what came very clearly is that there are strategies to bridge the gap around challenges, and we have each of the different countries have been implementing different strategies, so learning from each other is another aspect, I think, that came out clearly. There are important experiences and strategies that different countries have been implementing to address the challenges around data. Let's learn from each other. That is one of the key takeaways. The second one is, in addition, I think, to the development and design of products and commodities, it's very important also to consider how to deliver these commodities to those who need it effectively. The presentations from the different presenters alluded into that, and this requires collaboration among different actors. Not only the traditional collaborations we are talking about, but collaboration also at different levels, including at the community level, the different actors there that are important for the different contexts. The third one is around the introduction of MMS and the switch between IFA and MMS. That is, I think, a lot we've listened around that, but the key takeaway around that is that switch from IFA to MMS should be taken as an opportunity to strengthen the antenatal care platform as well as the women nutrition strategies, because we know in most of the countries, low and middle income countries, we know the challenges around antenatal care service delivery we have. So this could be used as an opportunity, the way that Ethiopia has been using it as an opportunity to strengthen the platform, not only the service delivery side, but also the demand side, improving adherence of the supplements in the communities. The other one is the importance of supporting continuous innovation. We heard from the FITES example on that, which is very important to enable us to develop alternative solutions for the different problems we are having. The iron absorption and then supply case is a case in point. So the importance of continuous innovation. And the last one, I think, is the intervention that's made by Ramadani in terms of the importance of going beyond the health facility and the health sector to also start thinking about the fact that households and communities produce their own health. They have a very important stake in whatever we do. So we'll have to work towards also empowering them in terms of really equipping them with the knowledge, skills, and capacity to address the problems that they can address at their level and building their resilience as well. So these are, I think, the key takeaways that stood out for me. I'd like to thank the two panels, the data panel for their very interesting and useful insights, as well as the commodities panel as well, and all the participants for your staying to the end of the conversation. So thank you very much for Kalpana as well for your excellent facilitation. Thank you.